Welcome to the Barrier Breakdown, Disrupting Mental Health podcast, where we talk about the clinical and practical issues that face those working in the mental health industry.
Everyone, and welcome to the Barrier Breakdown. My name is Erin Molyneux-Bailey. I'm the Chief Operating Officer at Cognitive Behavior Institute, and my co-host, Dr. Kevin Caridad, who is the CEO and founder of Cognitive Behavior Institute. This is our first episode of 2022, so we hope that all of our listeners are having a calm, I'll say, and great start to the new year. Today, we are joined by Dr. David Kraus, who previously served as an assistant professor of child psychiatry at University of Massachusetts Medical School, and now serves as the founder and president of Outcome Referrals, which is a world leader in providing cutting-edge outcome management services for more than 30 years. Dr. David Kraus is also the inventor of 2 U.S. patents, including one that controls the use of outcome data to make referrals in any field of medicine. So Dr. Kraus, thank you so much for joining us here today. And our listeners, can you share a little bit with us on how you became interested in mental health?
Sure. And given my advanced age, maybe this takes me back quite a ways. 40 years ago, I think. It was a memorable summer. I was in college. I was an econ major up until this event. I loved working with kids, but I thought it was fun. I thought it was play. So I'd recharge my batteries during the summer working like at summer camps. And then I'd go back to dealing with math and statistics and economics. And then I had just gotten my certificate in being a lifeguard and took a job at a psychiatric hospital being the lifeguard for their pool just outside of Boston. And I still remember the charge nurse shaking her head and saying, "I've got to hire you, but you don't know what you're doing. I've got to put you on one of the units because the pool's only open 2 hours a day, but these are violent kids. They're scary. You don't know what you're doing." And I kept remembering those words through my head. Just sit in the background, follow the lead of other people. You don't know how to restrain kids. You don't know how to put them in 4-point restraints. And by the end of the summer, I was kind of their go-to person for the kids that were the most kind of disturbed, frequently in and out of restraints. My favorite kid, I'll call him Arlo, was this 4-year-old kid that spent most of his time in the hospital in the seclusion room, locked up. He was 4 years old. They said he was psychotic. He put his fingers into the wire mesh and just sit there and rock and bang. And then one day while I'm the lifeguard at the pool, he comes walking out with the rest of the kids fully clothed because they could never get him to take a shower, change his clothes. That's when he was the most violent, most upset at life. And he walked right over to the fence and started doing the same thing, banging his head on the fence and kind of grunting. He couldn't really talk. And as I'm sitting there watching him, I realized that it is the dumpster out in the parking lot that he's been watching from the seclusion room and from the fence, and specifically the crows that were swirling around, fighting with each other over what was in the garbage can. That was mesmerizing him. And so I had a 5-mile commute to work every day on my bike, rain or shine. And I started practicing how to caw like a crow. And when I finally thought I was really good at it, one day as I was walking by the seclusion room and the door was unlocked and it was open, which was the kind of sign of, let's see if he can reintegrate back into the community, I cawed, and it instantly caught his attention. He whirled around and he just marched right out of the seclusion room and followed me to the kitchen. And I poured a bowl of cereal for him and myself, and we sat down and ate. Staff were mesmerized. They were, and I think it taught me that you just really have to meet people where they are.
Wow.
Anyway.
Yeah, so it sounds like
pivotal point.
Being not their first choice for lifeguard, they were just incredibly taken aback by your ability to adapt and relate to this individual.
And I instantly realized I had a different kind of calling in life, if you want to So,
Oh, I love that. Yeah, that's very cool. So we can see how clients, so this is a perfect segue to kind of discuss your research on therapist and patient matching, because those relationships and meeting people, really go to, what we're here to talk about today. So can you tell us a little bit about your research, and we'll kind of chat about that topic.
sure. Yeah, I got interested in the topic of measuring outcomes and figuring out how to use it for this kind of matching process maybe about 8 years after the event I was just describing. And if I gave Arlo the credit for changing my career, I'll give Hillary Clinton the credit or for changing this focus of my research. I still remember what she said at the time. President Clinton had put her in charge of national healthcare reform policy. And one of the things she said in a speech is it doesn't matter whether you're an ER doc or a psychiatrist, if you can't show on average that your patients are improving from your care, you probably shouldn't be in the profession. She probably said it softer than that, but that's what I heard, and it made perfect sense to me. But at the same time, the kind of scientist in me said, they're going to get it wrong. They're going to measure this wrong. They're not going to risk adjust the data properly. And for those of us, like I considered myself, working with the most disturbed kids in the state. I was now working at UMass Medical School. I thought it was the perfect job for me, running the inpatient unit for the most disturbed kids in the state. How could you possibly compare my outcomes to somebody that deals with adjustment disorders in a school population? Like, it doesn't make any sense to me. So we got to perfect the science. And I've basically been on a 30-year quest to make that science really good. And then figure out what to use it for. I would say there are 3 big studies that we've published to date. The biggest one is the one that JAMA just published in September, which is the first randomized clinical trial of a referral process in healthcare, all fields of healthcare. And what we were able to show is that how you refer, how you assign cases is as or more important than treatment itself. And when you do it wrong, clients get worse. And when you do it well, clients have amazing progress. And so when I started measuring my own outcomes, I realized I was good at treating kids and families with multi-generational histories of trauma, but there was a subset of my clients that I was horrible at. And by horrible, I mean really bad. So if you take kids, adolescents that have significant substance abuse issues, they ended care with more substance abuse problems than it started. That's not good. And our data shows that all of us, for the most part, have areas where we are harmful. We don't know it. And if we can identify it and eliminate it, great things do happen. And our study that we published in JAMA was a very simple, elegant design. Once we had discovered that process, we went to the Cleveland Clinic. We went to their primary referral pathway out into the community. So when the family medicine clinic at the Cleveland Clinic wanted to refer to behavioral health, they referred to this practice out in the Cleveland area. And the therapists that were involved in the study saw patients in both groups. The control group was they matched the clients to providers based the way they had for many years, which was people would raise their hand and say, I'm really good at anxiety disorders. I'm really good at substance abuse. I'm really good at depression. And the intake staff would assign cases based on those self-perceived strengths. And they were getting good outcomes. They were getting, based on our data for millions of patients across the country, they were getting risk-adjusted good outcomes. But by figuring out and looking scientifically at how they did with their last 30 patients and using that to predict how they're going to do with their next 30, we were able to double those outcomes. We didn't change anything that the providers did in treatment. We didn't tell them that they had to use CBT or some other evidence-based treatment. They were able to do what they thought was best. And so by just simply assigning them cases that they had historically hit out of the park and done really well with, we were able to double the outcomes. The outcomes were rather staggering. The average client ended care about not just within the general population average, but at the general population average. And they maintained those gains for at least a year.
Were you able to identify any subsets of the characteristics of what specifically is being matched?
Well, in terms of being matched, we actually had tested 5 different algorithms of how to match. The best match that was able to almost triple the outcomes for patients was matching on making sure first and foremost that they were not causing harm in an area that was important to the client. So for example, don't give me somebody that's got a substance abuse issue or a family with a propensity for it. Number 2 is to match on their 3 primary issues that the client had that were the most out of the norm. So let's say they were the highest on quality of life, school functioning, and anxiety. And if you matched on all 3 of those and eliminated harm, clients came close to tripling. Okay. We also found specific kind of client characteristics that mattered most. So those that self-identified from a minority group benefited more from care, from the matching, as well as patients that had more significant issues to begin with.
Fascinating. How does the matching, so how do you do that assessment, right? So, you know, a big population of who's watching us are these outpatient clinicians, either individual groups or otherwise. How does this get operationalized in a kind of an open system where it's kind of these, in this, as we describe?
Yeah, so one way to do it is the same way we did it in the study. So it was called Psychological and Behavioral Consultants outside of Cleveland. They had been using our system for a number of years. We already knew what the strengths were with the clinicians based on the outcome data. So a big part of what I've done over the last 30 years is creating a really good scientifically predictive outcome assessment tool that only takes about 5 to 7 minutes for the client to complete it intake. They complete that for an outpatient kind of practice, usually about monthly during care. And that data, there are like 23 randomized clinical trials that have been published in JAMA that show that by doing that, you greatly improve outcomes to begin with. So they had already reaped that kind of benefit into their program. And then we just installed what we call the match button into the software that they had access to. And so when the client was randomized to the match condition, the intake staff clicked that button, had a short list of the providers instead of the, whatever it was, 250 clinicians in the Cleveland area that they could get matched to. They had a subset that were really well matched, and they just had to pick the clinician that was in that subset. Since the JAMA publication, we've just released a consumer-driven version of this, where you can go to matchtherapist.com and for free, consumers can complete the same assessment, take 5 or 7 minutes, and then look for the matches that are really well matched to them. It's currently only in a kind of public beta release because we need lots of providers to be able to make that work really well. But you can see real providers that are matched all over the country. They just may not be in your backyard, that are in what we call that A+ matching, where you get the double to triple the outcome benefit.
Gotcha. And so this is patient driven. It doesn't have to be, in a sense, given by a clinician.
So we have both versions. One is that on our kind of wellness, what's called wellnesscheck.net platform, and that's the provider-driven platform where providers can decide how and when they want to assess their clients' outcomes and click the match button. And then consumers can also drive the bus. And I think in the long run, it's consumers that are going to decide, how do I find the therapist I really want? Right now, I'd say they're mostly looking on like Psychology Today, which is like, to me, a glorified yellow page listing.
No, I agree with you. I think some of my experience in at least the local community here is there's such a volume due to the pandemic and everything else that's going on. People are just taking whoever they can. I'll say at a place like Cognitive Behavior Institute, we're always looking to, we're measuring psychometric measures over time, trying to see it. We're using OpenFit, which you've probably heard of, Scott Miller's work to try to get better outcomes and be predictive. I'm wondering, have you seen the application or the administration self versus through a clinician, the efficacy of that measure, what it's intending to measure, being the same, or is it that much different? And why I ask that is someone like me, it's like I have, 60 therapists. If I want to match better where we can, it may be worthwhile that I'm not going to give them the next opening. It may be worthwhile them waiting whatever to get to this cluster. How does a practice go about it? That's a large group practice like I'm speaking of.
Yeah. So yes, measuring outcomes in any way is better than no way at all. So you're well ahead of the game there. But I would say the most important thing is to have an outcome system that has extremely good construct validity, which just comes from confirmatory factor analytic work, where you're able to show that I'm really measuring well depression, anxiety, and the other things that I could be treating. And it's only with something that's really robust like that you can do the matching. Because otherwise you're just finding who you think are the best clinicians, as opposed to who's best at what. So, for example, anxiety, depression, and so forth.
And so your system is you can put the data on both sides, the therapist and as a
yeah. So to your question, which is better? If you're going to do one, the client is far better than the therapist in being able to predict and use that data to figure out a good matching algorithm.
Yeah. Now I was just thinking, hey, what would it be like to somehow integrate your system where I could have a client fill it out and then our systems match because we have the dynamics of what the therapists are, and it happens that way. It seemed like that'd be a really cool way to get our ways of learning outcomes. So that's awesome. Cool. What's next for the research?
Well, we have our next federally funded grant that we hope will be approved in the next days. PCORI, the federal arm or quasi-federal arm that came as part of the Affordable Care Act, funded the first trial, and they're about to hopefully pull the trigger and fund an expansion of that into the real world, not with a randomized clinical trial, but it showing that it works really well in a large population. So we'll be able to announce that soon. We have health plans like Aetna, extremely excited about how this can really help identify and solve the quality problem, because the quality problem is quite serious, even though we're all aware of the kind of access problem that's currently out there with the pandemic and people trying to find care. Currently, 60% of consumers find no meaningful benefit from care. And so finding good quality care is an essential part of solving the problem. And so part of our next round of research is to also look at other ways to match, not just clinically, but for example, on some demographic variables, they usually on average don't make any difference in terms of the matching. But for a certain subgroup, when they self-identify, this is really important to me that I have somebody as a therapist that is, for example, not of my religion, because I feel somehow persecuted by my religion. That is obviously probably a very important thing to study. Also for the LGBTQ community, finding somebody that has helped other people deal with the exact same type of struggles, whether it's my gender identity or whatever, those things are, I think, hypercritical.
Okay, great.
Yeah. Can you oh, go ahead, Kevin, we're going to say something. I was going to say, can you share with our listeners where they can read online about your research? And then can you also share that website that's in beta one more time for our listeners?
Yes. It's matchedtherapists.com. And that's the best way to find the research, both synopsis of it and the actual reference to the articles, as well as kick the tires on it. Pretend you're a patient, see how easy it is to work.
Yeah, I like that idea of pretending you're a patient. I know that that can provide some really useful feedback, switching shoes, so to speak, and kicking the tires. Is there any kind of piece of advice that you would give to clinicians who are, interested in kind of learning more about this?
Yeah, I've thought long and hard about those kind of questions because it's a rough one. The research shows that we are not good at predicting what we're good at or bad at. So for example, Michael Lambert at Brigham Young has been studying this for a long time. He hasn't found a single therapist that's good at predicting what clients will get worse in care. His most impressive study to date was over like 440 patients, and not a single experienced clinician could predict which client was going to end care worse than when they started. The only one that got it right on one patient was a student. And so we're not good at it. We're good at providing hope. We're good at walking into care feeling like we are the best match. That is our job. And so what I would say is when we're in session, use your instincts, especially if your outcomes are still look great. But outside of session, when trying to figure out who is the next best client to walk in my door and for me to help, you really do have to look at the data because it can have a powerful effect.
Yeah, no, absolutely. I mean, the thought of turning a client down because the data, explains to you that you may not be good at working, may not be the best choice, with working with that population, I think is something that even in a pandemic, when there's such a need, is really complex. So yeah. Absolutely. Wonderful. Well, thank you so much for taking the time to meet with us today and kind of go over your research. It's definitely fascinating, and it even leaves me with lots of things to consider, even in our whole intake process and how we screen. And, like you said, that self-reflection piece of what are you a good clinician. I know Kevin, our Center for Education, is constantly looking to, that was something that came out of our whole mission, was to not just provide training, but to provide really high quality training, so that there is, that certification piece, there is, that more in depth.
There's a new domain to look at now.
Yeah, exactly. Wonderful. Well, thank you very much, Dr. Kraus. We certainly appreciate your time, and we'll be definitely looking into more of your research to come. So thank you for joining us today.
Yeah, thank you.
All right. And thanks so much to our listeners for tuning in this week on the Barrier Breakdown, and we will catch you guys next time. Take care.
Thank you for listening to the Barrier Breakdown, Disrupting Mental Health. Listeners can find all of our episodes on YouTube, Apple Podcasts, Spotify, and Podbean. For more information and to learn about upcoming continuing education events, check out our website, cbicenterforeducation.com, our Facebook pages, Cognitive Behavior Institute and CBI Center for Education, as well as our Instagram at Cognitive Behavior Institute and our Twitter at CBI_Pittsburgh. Don't forget to like, comment, and subscribe. We hope you'll tune in for another guest next week.